Welcome to Emergency Insights, where we bring frontline knowledge to healthcare professionals worldwide. I'm James Carter, and joining us today is Dr. Emily Wang, an expert in internal and critical care medicine. Today's topic is a common but potentially dangerous electrolyte disturbance, hyponatremia. Welcome, Dr. Wang.
Thank you, James. It's a pleasure to be here.
Let's start with the basics. What exactly is hyponatremia?
Hyponatremia refers to a low sodium concentration in the blood, specifically a serum sodium level below 135 millimoles per liter. It's a frequent electrolyte abnormality, especially in hospitalized patients.
What kind of symptoms should clinicians be on the lookout for?
Symptoms can range from mild to life-threatening. Patients may present with nausea, headache, confusion, or seizures. In severe cases, it can progress to coma due to cerebral edema.
And what are the typical causes we should consider?
Common causes include excessive water intake, heart failure, kidney disease, liver cirrhosis, and the syndrome of inappropriate antidiuretic hormone secretion, or SIADH.
How is hyponatremia classified?
We classify it based on severity, mild, moderate, or severe, and also by volume status, hypovolemic, euvolemic, or hypervolemic. These distinctions are crucial for appropriate treatment planning.
Why is volume status so important in management?
Because it guides therapy. For example, hypovolemic patients typically require fluid resuscitation, while hypervolemic patients benefit from fluid restriction and sometimes diuretics.
Which lab tests are essential for diagnosis?
Serum sodium and osmolality, along with urine sodium and urine osmolality, are fundamental to confirm the diagnosis and identify the underlying cause.
One critical aspect is the risk of overcorrecting sodium. What should we be cautious about?
Rapid correction, especially in chronic cases, can lead to osmotic demyelination syndrome, a potentially devastating neurological condition. That's why we recommend correcting sodium by no more than 8 to 10 millimoles per liter within 24 hours.
And how should acute symptomatic cases be handled?
Those require immediate intervention with hypertonic saline, often 3% NaCl, under close monitoring, ideally in an ICU setting.
What role does fluid restriction play?
Fluid restriction is critical in managing euvolemic and hypervolemic hyponatremia to prevent further dilution of serum sodium.
Are there pharmacologic options for treatment?
Yes, vasopressin receptor antagonists, VAPTins, may be useful in select patients with euvolemic or hypervolemic hyponatremia who don't respond to fluid restriction.
How common is hyponatremia among hospitalized patients?
Very common, affecting up to 30% of inpatients, particularly those in intensive care units.
Which patient populations are most at risk?
Elderly patients, individuals with chronic illnesses, and those on medications like diuretics are particularly vulnerable.
If left untreated, what complications can arise?
Untreated hyponatremia can lead to cerebral edema, seizures, permanent neurological damage, or even death.
And finally, what's the overall prognosis?
It really depends on the underlying cause, the degree of sodium derangement, and how quickly and appropriately it's corrected. Early recognition and careful management are key to favorable outcomes.
Dr. Wang, thank you for these clear and insightful explanations. Hyponatremia is clearly more than just a number. It's a complex clinical challenge that demands our attention.
Absolutely. Thanks for having me, James.
That wraps up this episode of Emergency Insights. Until next time, stay sharp and stay safe.